Yeah. Yeah.
Welcome, good evening, and namaste, and a very warm welcome to everybody. I, Anita Jatana, consultant dietetics in the Pest Apollo Hospital, Delhi, would like to extend a very warm welcome to all our esteemed chairpersons, speakers, and participants for another dietetic lecture series in association with DAPIO, a global association of physicians of Indian origin, a non-profit organization which was established in 2011, long back. The dietetic session on pediatric celiac disease and diabetes management is a real challenging combination for us all when we are handling these young patients. Celiac, we know itself is challenging. Handling those young patients and those worried patients is tough enough. And coupled with type 1 diabetes is a real Hercules task. I think we'll all agree with that. Celiac in most cases is asymptomatic, goes undiagnosed and underdiagnosed, which results in consequences, we know, of decreased growth, delayed puberty, and anemia. And it is these symptoms that they mostly report with. And that's how they get tested for celiac. For most people, it's type 1 diabetes that is diagnosed before celiac. And it is recommended that these patients be screened for celiac, especially so as to be analyzed and implement the joint management. But of course, we have patients where it happens the other way around too. So you'll have the other way happening to some patients. Type 1 diabetes and celiac are one of the most recognized related autoimmune disorders as they share a common genetic background. Developing one of the diseases increases the risk of developing the other. The fact was first established long back in 1960s, and the prevalence of celiac in people with type 1 diabetes is about 6% as compared to 1% in the general population. That's a huge difference we see. So we have the experts. So over to the experts to enlighten us on this huge, difficult problem. A warm welcome to Dr. Srinivas, consultant pediatric gastroenterologist, who will be chairing the session. And the speakers, Dr. Sumit Arora, consultant pediatric endocrinologist, Artemis Hospital, and Ms. Cheryl Salis, founder, Future Health Solutions. So taking this forward, would like to welcome and invite Ms. Lekha Sridharan, a pioneer in pediatric nutrition and head of the Department of Clinical Dietetics at Apollo Hospitals and Women's Hospital, Chennai, with a rich experience of 25 years. A very close and dear friend of mine. He is the National Secretary of IPN India, got huge number of awards. One is Glantor Ex-Women Leadership Award 2022 and Sadhana Award, again, Clinical Nutrition 2002, and has presented various papers at national and international forums. So over to you, Lekha, to take this program forward. I would also request everyone to please be muted during the session and do post your questions in the chat box. Over to you, Lekha.
Yeah, thank you, Anita ji, for this wonderful introduction. And it's a great platform, like both the consultants and the nutritionalists are there together. And as the pediatric dietitian, I do understand how important when we work in a combo of such, we understand both the medical management and the nutritional management together. That's an excellent platform. And I'm happy and honored to introduce my mentor, I should say, Dr. Srinivas, because being the pediatric gastroenterologist from our unit, he had been a great mentor for me to train on many of the gastro section. And it's an honor to introduce him over here as the chairperson. So Dr. Srinivas is a pediatric gastroenterologist and hepatologist practicing at two leading pediatric tertiary care hospitals in Chennai. That is one Apollo Children's Hospital and the other lead hospital, Kanchi Kamukoti Childbirth. Sir has trained from Sanjay Gandhi PG Institute, Lucknow, and has been overseas training in Royal Children's Hospital, Australia at the year 2008. While he currently practices as the consultant pediatric gastroenterologist in this two hospitals, he also runs a general pediatric outpatient practice at his private clinic, Arogya Clinic. His special interests are childhood liver disease, inflammatory bowel disease, biliary atresia, and food allergy. He also deals with childhood metabolic disorders. sir. So it's my honor to introduce sir. Sir, over to you, sir.
Thank you so much, Lekha. Am I audible?
Yes, sir.
Okay. So it's a pleasure to always be associated with the dietitians here. And it's a pleasure to, I can't refuse when Lekha asks me to come and chair a session because I think we've grown together over the years and we've had many interesting conferences. And I always look forward to this interaction with the dietitians because it is certainly something that is important for us to work together and share our views and learn from each other. I am very pleased to also introduce the speaker today. Lekha, there are a lot of people who are getting admitted. Since I'm the co-host, I'm wondering whether
Sir, I have shared the screen. Is it visible?
No,
Yeah,
they'll get admitted themselves, so you can carry on, please.
Thank you. Thank you.
Yeah.
Okay. So I am very pleased to also introduce Dr. Sumit Arora. She's a pediatric endocrinologist who currently works at the Artemis Hospital. And she's got a very keen interest in diabetes. She's completed her 3-year clinical as well as research fellowship in endocrinology and diabetes in New York. And subsequently, because of her keen interest in diabetes, she's also one of the faculty for the ISPACE Ideal Program for Diabetes Educators. She's got an interest in insulin pumps and diabetes 1, and we are looking forward to her wonderful lecture.
Am I audible? Yes, am I audible?
Yes, you are.
Yes. Thank you, Dr. Srinivas, for that very kind introduction. And I would like to thank GAPIO, Dr. Anita, and all the organizers for having me here. And it is my immense pleasure to have Ms. Cheryl with me, who will be talking about MNT, medical nutrition therapy, and there's always something to learn from her. So I will start my screen share. Is it visible well?
Yes. Yeah.
Okay.
Dr. Sumit,
Okay. So Dr. Anita had really rightly mentioned that pediatric diabetes and celiac disease management is very challenging. And when they come in together, the challenge gets even more. And more than that, like we are seeing a lot of myths still in this day and very age that we need to bust. And also we're seeing some unphysiological insulin regimes. We're still seeing those food fads of not eating banana, not eating mango, not eating rice, even with type 1 diabetes. So those are things that we would like to bust here, and hopefully will expand the horizons of the management today. So the questions that we're going to address today are the burden of disease, what terminology should we avoid, challenges in diagnosing type 1 and type 2 diabetes. And for most part, we're going to be focusing on understanding the whys and hows in the management of type 1 diabetes. We look at some advancements and the association of celiac disease in type 1 diabetes, and looking at diagnosing celiac and its management. It's very disturbing to know that 1 out of 7 adults living in the world with diabetes are Indians. And out of that, type 1 diabetes, number of children and adolescents that we are seeing are roughly around 2 lakh, which is probably an underestimate because of the type 1 diabetes index that has been recently pointing out that we may be seeing figures of 8 lakhs. And roughly around 26,000 children are newly diagnosed with this type of diabetes every year. And the numbers are increasing significantly in the coming decades, about 68%. So we do want to understand the classification of diabetes before moving forward. And we should not be using these outdated terminologies like childhood diabetes, insulin-dependent diabetes, non-insulin dependent diabetes. Childhood diabetes, because of the rising incidence of obesity, we're seeing more of type 2 diabetes in children also. So that again should not be used. When we talk about type 1 diabetes, it's clearly impairment of insulin secretion because of destruction of beta cells, and type 2 diabetes is because of the insulin resistance, ultimately leading to dysfunctional insulin secretion. Then we do have some specific forms of diabetes in children as well. And because we are using a lot of genetic testing these days, these are coming into in front of us much more than before. For example, monogenic diabetes and neonatal diabetes that we are seeing more commonly these days. It is important that we identify these children who have these clinical features much early before they actually present with the DKA. So identifying the symptoms of excessive urination, unintentional weight loss, bedwetting in a previously toilet-trained child, lethargy, weakness, some skin infections or failure to thrive should raise the index of suspicion to test for diabetes. Now, it's very easy when we talk about a random blood sugar of more than 200 in the classic symptoms. Yes, we're talking about diabetes. Again, fasting blood sugar more than equal to 126, 2-hour post-load glucose of more than equal to 200, all are the criteria for diagnosing diabetes. However, when it comes to HbA1c, if it is more than equal to 6.5%, yes, it is a diagnosis of diabetes, but it's not always definitive. But firstly, because it will depend on the hemogram levels or if there's any hemoglobinopathies in the child. Secondly, if we're getting a lower level, does not rule out diabetes because it may still be in the initial stages when we're looking at. If we are seeing a child who has come in with classic symptoms, they are in the pre-pubertal age group, they have those classic symptoms, they have high blood sugar, they may or may not have ketoacidosis, we talk about type 1 diabetes. But if they are in the peri-pubertal age group, there is obesity, absent ketosis, then yes, we talk about type 2 diabetes, which is quite easy to say. But because we're seeing a lot of obesity these days, it may get challenging to find out which one's which at times. So if a child who has obesity is in the peri-pubertal age group, is presenting with ketosis, this may very well be type 2 diabetes because rarely ketosis can also be seen with type 2 diabetes. However, like if we are seeing peri-pubertal child who has severe decay, again with obesity, this may be type 1 diabetes also. So that's where your insulin antibodies come into play. We do need to check insulin antibodies to make sure to differentiate between these two clinical pictures. C-peptide may or may not be very useful. If it is high, then yes, we can probably say that it is type 2 diabetes. But if it is severe presentation of type 2 diabetes, we may be seeing a low C-peptide levels because of glucotoxicity. So in the rare forms of diabetes, if we are seeing a child who's presenting before 12 months of age, if there's a family history of diabetes in 3 generations who are presenting at a younger age, less than 35 years, the index of suspicion should go towards MODY. Or if there's syndromic features or certain exposure to drugs, we need to suspect the rare forms of diabetes. So when we're talking about management, it does not involve just the treating doctor. If we want the best outcomes, we want better glucose control, better quality of life, there has to be a team-based approach, which does include a dietitian and diabetes educator, a patient and the caregiver themselves, and a psychologist, because the initial diagnosis is very, very disturbing to them. And eventually also they do burn out and they have diabetes distress. So this has to be a team-based approach. And a step-by-step process is involved in the management of type 1 diabetes. So insulin therapy, starting them on basal bolus is just incomplete if we're doing it by itself, nothing and nothing else. We do have to make sure the rest of the steps are followed too. So diabetes education is one part, and that does include medical nutrition therapy. And then we have to make sure that the child is being checked for blood sugars at least 6 to 8 times per day, and an option of CGM should be given. And they have to be followed up and frequent adjustments may be needed. To understand how to start insulin, it's very important to understand the natural insulin secretion. So as you can see in the upper graph, this is the natural blood glucose levels that are maintained in a very tight regulated manner in our body. And when we see these fasting levels of insulin over here in the lower graph, we're seeing some degree of insulin always being released in the background to make sure that these blood glucose levels are maintained in a tightly regulated manner. And then we have these bursts of insulin that are seen with each meal. So we have this is how the natural insulin secretion happens. This is what we are trying to mimic when we are starting insulin as a basal bolus therapy. So we have the background insulin, which we give, and then we give prandial insulins, which is our bolus insulin. Can we please have the person mute? Okay. So we also want to make sure we're choosing the right insulin therapy. So understanding different insulins becomes very important. So these prandial or bolus insulins can be either the ultra rapid acting insulin, the rapid acting insulin analogs, which will work within 15 minutes, have a peak effect in 1 to 1.5 hours, and they last for 3 to 4 hours. Then we have the regular insulin, which will start working within 30 minutes. It peaks at 2.5 hours, and then the duration, it lasts for 5 to 6 hours. We have glargine and degludec, which are a basal insulin, which are making sure that there's a background insulin always there, and which are lasting the body anywhere between 20 to 24 hours for glargine and about 36 to 42 hours for degludec. So understanding these insulins will help us decide what insulins we do need to start for a child. But then also we do want to make sure that the insulin regime is tailored towards the socioeconomic status of the child. Also how the child's routine activities are, what kind of meals are they eating. So all those have to be tailored according to, those factors have to be taken into account when we are starting insulin. There are some other insulins that are available, like pre-mixed insulins or NPH&R, that are also sometimes used, but they are unphysiological. For example, if we are seeing here 70-30 mix, where 30% is the rapid acting insulin and the 70% is the background insulin. As you can see here, there's a peak here, but then there's some amount of stacking of insulin around lunchtime. If the carbohydrates are not taken enough, then this will be leading to low blood sugar, as seen in this picture as well. However, if you're taking excess amount of carbohydrates, again, another bolus insulin will need to be given. So this regime is an unphysiological insulin regime and does need a lot of consistency in the routine of the child. So having a fixed physical activity routine, having fixed meals, and not changing much into your routine pattern will be necessitated if we are starting this kind of insulin regime, which is practically not possible. So these regimes are not recommended by ISPAD also. So when we are starting insulin, it's also important to understand that what our carbohydrates are and what are meals that have an impact on the blood sugar. So carbohydrates do have a maximum short-term impact on the blood glucose levels. Then we have pattern protein that have a slow and delayed effect on the blood glucose level, which is to a smaller degree. And if we're able to match this insulin to the amount of carbohydrates that we eat, we have significantly improved blood glucose levels. We're able to give that flexibility to the child and significantly improve their quality of life. So that's where carbohydrate counting plays a big role and medical nutrition therapy plays a big role. To start insulin, it will depend on the physiological needs of the child if they are in DKA. So the total daily dose is calculated using this formula, 0.5 to 1 units per kg per day, and half of it goes to the basal calculation dose. And this may be lower if they are a younger child. And bolus dose can be calculated using these formulas, which are the insulin sensitivity factor is calculated by 1800 divided by the total daily dose. And the carb ratio can be calculated by 500 divided by the total daily dose. We do have to keep in mind, we can either give fixed carbohydrates to the child, or we can give this flexibility for counting the carbohydrates and give them a carb ratio so that they can, easily adjust whatever they are doing in terms of their meal routines. However, there is no fixed dose regime that is usually there because sugars will vary throughout the day, and bolus insulin adjustments will be needed. So it's important for us to understand that we do need to give them a sliding scale also along with their doses of bolus so that they know how to adjust their blood sugars. There was a survey that was conducted in 2013 for those people who had type 1 diabetes, and this showed that feeling in control of their own care was rated much higher and more important than factors like fewer finger pricks. So if we are giving them the control of them able to eat their carbohydrates freely, and then them able to bolus according to their carbohydrates, it gives them much more flexibility and improve their quality of life significantly. Let's look at some advances in the technology. So now we have glucose monitoring devices that have been there for the last 2 decades or so. And ISPAT strongly recommends to use these CGM devices. What are they? So they are monitoring devices that are placed on the skin, as you can see in this figure. And it has a filament that is sensing the interstitial fluid glucose. And every time you're using the sensor, you can look at the readings accordingly. There are different that are available in the market. One is blinded more for professional use. Then we have this intermittently scanned device where you're using this device to scan the sensor and you get a reading along with a prediction. Then we have this real-time CGM where you're constantly getting a graph and the blood sugar readings are updated every 5 minutes. We also have an implantable sensor that can be placed in the abdomen, and you can get the readings over the phone, but that's not available in India. When we are using CGM, continuous glucose monitoring devices, it really helps to improve the glycemic control. Let's look at this patient. Now, she's an 18-year-old female who was diagnosed with type 1 diabetes and was started on twice-a-day premix insulin. Her initial HbA1c was 12%. 6 months after treatment initiation, HbA1c dropped significantly and improved to 6.2%. And her fasting BGs are 80s, post-meal BGs are 180, and occasional 200s. So that's excellent. But she still went ahead and seek second opinion. A blinded CGM was placed. And this was an eye opener for her. She has had like multiple lows, and this is a real patient of mine. Her time below target has been around 30%, 33%, which is giving a false reassurance to the HbA1c, where we are seeing an HbA1c of 6.1%. So that's normalizing the HbA1c. So the sensors do provide a much accurate picture for us. Let's look at the goals of glycemic control and HbA1c. So the target HbA1c is less than 7%. And if we are in remission and using CGM or advanced pumps, then it can be as low as less than 6.5% without compromising on low blood sugars. More than HbA1c, now people are favoring, more and more guidelines are favoring using these targets of CGM, which is time in range, where your blood sugar should range between 70 to 180 in more than 70% of the times, time above range of more than 180, less than 25% of the time, above 250, less than 5%, below 17, less than 4%, and below 54 in less than 1%. And these are the targets we would like to achieve. Moving on to insulin pumps. So these are medical computerized devices that are able to deliver small amounts of insulin using one rapid acting insulin and deliver it constantly at a constant rate throughout the day. So which is going to take care of your background insulin. And whenever there is a need of a bolus insulin, a large amount of insulin can be entered into the body using the same device, using those correction formulas and carbohydrate ratios that we talked about. And so instead of injecting 4 injections per day, now the site can be changed, the infusion set can be changed once in 3 days. These are the parts of insulin. So as you can see here, this is the reservoir where the insulin sits. This goes inside the pump, and this is the infusion set that attaches to this reservoir, and this tubing is connected to this catheter, which is inserted into the body, into the fatty tissue, and the insulin is delivered constantly through this pump. Not only the number of injections decrease and there is more convenience, but also we can see that we can adjust the basal rates depending on the need of the child. So it's not a constant one single shot of background insulin that we're giving. We can actually vary the need of the basal rates based on the insulin sensitivity of the child, which can actually vary throughout the day. Even with bolus insulin, we can give smaller amounts of bolus doses as low as 0.01 units per dose when we're using these insulin pumps. Previously, we had only standalone insulin pumps where they would not change the insulin doses according to the sensor. But now more and more recently, we can adjust the insulin based on the sensor readings. So the sensor and the insulin pump can actually talk to each other, where the sensor will send the signal to the pump if the blood sugars are starting to trend up, and based on an algorithm, the insulin delivery will start to be adjusted. So if there's a prediction of a high blood sugar, the insulin dose will increase, or if there's a low blood sugar, the insulin dose will also start to increase. So that's where we are right now in terms of the current insulin pumps that we have, the advanced closed loop hybrid technology that is also available in India. This is how the pump download looks like. And as you can see over here, this B reading is from when the insulin pump was started, whereas A reading was a month later, and you can see the time in range was significantly increased to 76%, and we have achieved all the targets that we are supposed to achieve. So, and a peek into the future, we are hoping for a cure and further advancements. We're looking into stem cell-based therapies that are being worked on, gene therapy, and maybe a vaccine or immunotherapy to prevent the onset of type 1 diabetes. I'm not going to go into type 2 diabetes very much because of lack of time. We are seeing a significantly rising incidence of type 2 diabetes in children. The risk factors are poor lifestyle, body mass index in obese category, family history of type 2 diabetes, history of SGA small for gestational age babies, gestational diabetes in the mother while the baby was there in the womb. Screening at 10 years is recommended with increased BMI, or it is earlier if there is any one of these risk factors that are present. And diagnostic criteria we've already talked about. Management, if the HbA1c is on the lower side, less than 8.5%, metformin can probably work alone. However, if we are talking about high blood sugars, then basal insulin or basal bolus insulin may need to be started along with metformin. And more recently, we're looking at newer agents of GLP-1 agonists that are approved for adolescents. Moving on to celiac and type 1 diabetes, as Dr. Anita had mentioned, there's a significant rise in the prevalence to 8 to 17% in Indian studies. However, the global prevalence is 6%, and the co-occurrence of type 1 diabetes and celiac is actually 5 to 7 times higher. Because the genetic predisposition has a common link between type 1 and celiac, we're seeing the risk of higher incidence of celiac disease also. As Dr. Anita had mentioned, the more common presentations when celiac disease is a standalone as failure to thrive, short stature, or vitamin D deficiency rickets. But with type 1 diabetes, it may be asymptomatic at diagnosis. Also, it has been noticed that they may have lower body mass index. They may be failure to thrive. But the impact of celiac disease on type 1 diabetes itself can lead to a lower HbA1c because of malabsorption. There may be risk of hypoglycemia prior to diagnosis and in the first 6 months. And there's no difference in the HbA1c once gluten-free diet has been started. So it's important to screen at diagnosis in the first 1 to 2 years and then every 5 years. And the screening test is TTG-IgA. It's very important that we counsel our patients not to start gluten-free diet, and only after confirmation has been made with endoscopy and biopsy, then only the gluten-free diet has to be initiated. Management is gluten-free diet we have to start. We do want to make sure that micronutrient deficiencies are taken care of, and they have started to have their catch-up growth once the gluten-free diet is started. And they're also on strict gluten-free diet, and the titers have come back as negative on follow-up. And there's a lot of challenges with gluten-free diet. I'm sure Ms. Cheryl is going to talk about it. I don't want to talk more about these because we're already short of time. So takeaway points, type 1 diabetes is a team-based approach. Basal bolus insulin therapy is much more physiological. Please use that. We do want to recommend CGM sensor because it gives a clearer picture. Screening of celiac disease is very important at diagnosis of type 1 diabetes, and gluten-free diet should be started only after biopsy confirmation. Thank you for your patient listening. I'll move it over to Dr. Srinivas.
Thank you so much, Dr. Sumit. I think it's a very, very crisp lecture with clear-cut points, takeaway points. Do we have questions now, or do we want to have questions at late?
We'll have them at the end of the session, sir.
Okay, okay. So we move on to the second lecture. We want to introduce Ms. Cheryl. Okay, so I'm very pleased to introduce Ms. Cheryl. She's the founder for Nurture Health Solutions. She's got 23 years of experience in the field of dietetics and diabetes education. She's successfully completed her science school, ISPAD at Boston, and Alan Rice Fellowship at Australia. And she's an advisory council member of the ISPAD. She's also the author of award-winning book, Diet in Diabetes Simplified, and a co-author of the ISPAD 2022 Nutrition Guidelines for Type 1 Diabetes. And she's also the author of various chapters in other medical textbooks. She's also the course director and the visiting faculty and trainer at various educational institutions. May I welcome Cheryl to deliver her lecture.
Thank you so much, Dr. Srinivas, and it's wonderful being here with all friends. I see a lot of friends in the delegates also, so it's really nice. And I will begin my presentation. Just give me a moment to share my slides. Are my slides visible, Lekha?
Yes, Cheryl, you
I'm
can.
audible?
Yes, audible.
Okay, so my topic is MNT in type 1 diabetes and celiac disease, and everybody knows my passion for type 1 diabetes, and we're definitely seeing an increasing incidence of celiac disease, even in the part of the country that I am from. Though we know that in South India, we really do not see too many celiacs, but I think because of people migrating now from north to south or from other regions, we're also seeing some amount of celiacs there. But yes, the number of people with celiac disease has gone up, and type 1 and celiac disease is a very common occurrence that we see in our clinical practice. The outline of my talk is macronutrient recommendations in type 1 diabetes, carbohydrate counting, synchronization between types of insulins and meals, beyond carb counting, protein and fat counting, and MNT in celiac disease. And Dr. Sumit has already spoken very well on the management of type 1 diabetes as well as celiac disease. And I'm going to be touching upon the nutritional management of both these conditions. For children with type 1 diabetes, we follow the ISPAD guidelines, and we had our latest ISPAD guidelines released late last year, and I was very honored and privileged to be one of the co-authors with other dietitians across the world. Now, the goals of MNT in type 1 diabetes, again, it's very different to managing people with type 2 diabetes or with gestational diabetes because they are children and adolescents, and we have to ensure normal growth, development, and maintain a healthy weight and BMI. Again, today with, so many different insulins, like when I started my practice 23 years back, we just had short-acting insulin, NPH, and pre-mixed insulins. We also had few of our, patients on pre-mixed insulins. But today, clearly, as Dr. Sumit rightly said, that these ISPAD guidelines clearly state that children with type 1 diabetes should be on a basal bolus regimen and not on pre-mixed insulins. And therefore, with the wide variety of, the range of insulins that are available, like fast-acting, rapid-acting, regular-acting, NPH, and long-acting insulin, each prescription will call for a customized meal plan. we are trying to achieve good glycemic control by trying to minimize hypoglycemic episodes, because that is our first goal, trying to achieve a good A1C of less than 7% and 70% time in range, which we are able now to see with the CGMS becoming a very, very value-added resource and tool in our clinical practice. Minimize short-term and long-term complications. Again, modify the meal plan if hypothyroidism and celiac is present, because this is something that we do see. Again, it's a stepwise tailor-made approach, because usually when the child is diagnosed with type 1 diabetes, it is like an earth-shattering moment for the parents. They've never heard of type 1 diabetes. We all eat food. We do not count carbs. We do not count protein. We do not count fat. And especially when it comes to children, they just eat when they want to eat, and they eat anything that they want to eat. And today, definitely, that has become a big, big challenge. And like Dr. Sumit rightly said, we're also seeing an increased incidence of type 2 diabetes in our in children in our clinic today, and obesity is definitely on the rise. Hyperinsulinemia, PCOS, type 2 diabetes also in children is on the rise. So therefore, very important is the right diagnosis. Then comes to assessment. So doing a dietary assessment, because most of these children are presented in the hospital ICU with diabetes ketoacidosis. The parents are in denial. They are in shock. They're wondering, they're trying to go from one doctor to another, going to spiritual gurus to look for a cure. So there's a lot happening on that front. And suddenly they're, being told that they have to monitor the blood glucose level so many times a day. They have to take insulin injection shots. They have to count the carbs. So it becomes very overwhelming for the parents and the caregivers in the beginning. And therefore, it has to be a stepwise, tailor-made approach. We take a detailed assessment. One is as to what is the child really eating and what is his kind of routine, because he's also going to school. There is sports activities that he's involved in. There's weekend, so taking a thorough dietary recall, understanding what is the energy and nutrient requirements, plotting the growth chart, looking at the growth trajectory, principles of healthy eating, synchronizing insulins with meals, like I said, and I'm going to discuss it in the slides to follow. Carbohydrate counting, protein and fat counting comes much, much later. And very important is that these children and their parents require a lot of hand-holding and timely follow-up. So it's not like a one consult and you're done. We're regularly in touch with these children and parents, sometimes even late in the night and early morning. Now, energy requirements are calculated just like any other child with similar age, weight, gender, and activity. They're higher than normal soon after diagnosis because there's loss of weight, and very important to restore the lost weight and energy. Higher in puberty, and first year after diagnosis is a very critical period, because sometimes if they're taking more amount of insulin and they will also result in more insulin resistance, causing obesity and double diabetes. Again, now the ISPAT guidelines, these are the 2022 guidelines which have been revised, and the carbohydrate recommendations are 40 to 50% of energy coming from carbs, looking at, providing low glycemic index, low glycemic load carbohydrate sources, moderate sucrose intake. So if the child wishes to consume sugar, then that should be accounted for in the carb intake, and it should be less than 10% of the total energy coming from sucrose. Fat is 30 to 40% of the energy, especially we're trying to meet energy requirements, moderating the carbs. Then MUFA fats, especially coming from your nuts and seeds, become a good option, and they're also low in carbs. It works very well when a child wants to eat something in between and does not have an insulin cover. Protein is 15 to 25% of energy, and fiber recommendation for children is age in years plus 5 grams. Now, we all know about the Jocelyn healthy food plate, and this has made our clinical practice, nutritional recommendations very, very easy and simple for the person to understand, because by just doing this, one is we're ensuring diet diversity, nutrient density, and ensuring that the child is eating a nourished, balanced diet. Now, there are a lot of parents who, insist on putting children on a low carb diet, because there are a lot of adult type 1s today who are, on a low carb diet, and, they show their CGMS graphs, they show a straight line, and all that the parents are trying to achieve is that straight line on the CGMS without realizing that it can have a long-term impact. We do not have long-term studies to show as to, low carb diets in children, what is the kind of outcomes, and therefore ISPAT 2022 guidelines have very clearly stated that we should not go very low on carbs. And honestly, in my own clinical practice that I have seen that even moderating the carbs to 45 to 50% does really well. And we are able to achieve a good time in range. And today with the advanced hybrid closed loop pumps that have come in, we are even achieving time in range of more than 95% to 100% with our children. There's a lot of effort, there's a lot of hand-holding, monitoring that goes in, but yes, it is achievable. Low carb diets, as we all know, if it's not really well planned by a qualified dietitian, it can, one is that it leads to a lot of deprivation, because the children, when they're going out with their friends, it becomes very, they're deprived of a lot of things that they want to eat, and it's not sustainable. Secondly, is it can be nutritionally inadequate. We all know calcium, B vitamin, iron, fiber. Again, because a lot of these low carb rotis that you see that are available, the atta that is available in the market, they're very high in fiber, and often they will add more fiber in the form of psyllium husk, oat bran or wheat bran, and therefore, again, fiber will hinder the nutrient absorption, and we are definitely seeing an impact on the hemoglobin levels. Increased risk of disordered eating behaviors, which is also becoming an increasing concern today. And therefore, it's very important to counsel parents and understand their concerns and, put them to rest. Because if you tell them not to do it, they're going to go to somebody else who's a quack and who's not trained and do it, and then land up with, problems and complications. And therefore, it's very important to sit down with them and counsel them. Now, in the big, again, when I look back at my practice 23 years back, there used to be a prescription that came to us. We really didn't look at the type of insulin. We just gave food for the insulin because we were always afraid of hypoglycemia. And therefore, the child was asked to eat every 2 to 3 hours because of the fear of hypo. But today, with the modern insulins that have come in and the analog insulins for a rapid acting or a fast acting insulin with a long acting analog, again, it's very, very simple, where we use carbohydrate counting, the insulin to carb ratio, and we give insulin for the food. So if the child is less hungry, the child takes less amount of insulin. If the child is more hungry and wants to eat that extra roti or half a cup of rice extra, he can take more insulin and cover his meal and achieve good glycemic control. Now, as we all know, why do we count carbs? Because they have the greatest short-term impact on blood glucose levels. Again, if you look at our Indian home-cooked meals, and we all have enough surveys and studies to show us that India is deficient in our protein intake, even if we are non-vegetarian. Some of us who are non-vegetarians still eat less protein than our requirements. And protein and fat take up to 3 to 4 hours to show up as blood glucose levels. But however, in our home cooked meals, it may not really have an impact, because only when it is, when the protein amount is more than 30 grams per meal and the fat amount is more than 20 grams per meal, will it have an impact? And I'm going to discuss that in the slides to follow. Again, we do the carbohydrate amount and insulin to carb ratio, and therefore the parents are taught as to, which foods have carbs and what are the amount of carbs that are present in which food. Again, we can't get 100% accurate with our carb counting. Every Indian household will cook food differently. Some of them, especially if you look at the western part of India, they would add jaggery or sugar to the food, even to a dal or a vegetable, and therefore the carb count can go up. And therefore, a lot of studies that have been done have shown that up to 20% of plus minus, in terms of the carb counting estimation is fine, and it really does not impact the blood glucose levels adversely. Today, it's very important to counsel our patients that SMPG and CGMS both are very, very important, and has to be done for us to be able to see that the blood glucose levels are in range, and is the insulin to carb ratio working well. Now, again, like we mentioned, that people do not know which foods have carbs, which do not have carbs. Even if you ask our family members, they may not know. And therefore, it's very important to educate them on which foods have carbs. And if you see most of the foods that we eat, they do have carbs. And a lot of people, if you ask them, what did you eat? And they'll say, we ate roti and vegetable. And we ask them which vegetable, and most kids will eat a potato vegetable. And again, we know that potatoes do have more carbs than our other non-starchy vegetables and need to be accounted for. There are a lot of myths and misconceptions about honey and jaggery. People stop using sugar and replace sugar with honey and jaggery, which we all know has carbs and similar calories. when we ask them to have yogurt, they'll go and have the sweetened yogurt, and that again will contribute the carbs. Milk again will contribute the carbs. Dals, a lot of people think that dals have no carbs, but we all know that if you take 30 grams of raw dal, it will give you 15 grams of carbs. A lot of people have now started switching from wheat to other millets, and we all are celebrating the International Year of the Millets. However, it's very important to educate our patients that whether they shift to bajra or jawar or any other millet, roti or rice, it will still contribute to carbs and has similar carbs to wheat. So this is the 15-gram carb exchange. And, we have so many different kinds of food. India is a very diverse country, north, south, east, west, and even today, a lot of people are experimenting with different cuisines. Like today, we had somebody who went and had a Burmese meal for lunch, and Chinese and Japanese and Thai. And again, it's very important to get the carb estimates right. A lot of our children also eat out of packaged foods, and you have a lot of enticing, food packets which say that they're sugar-free. However, it's very important to educate them that sugar-free does not mean carb-free or calorie-free. So educating them how to decode food labels, read the food labels and count the carbs for the portion that they're eating is again very important. Now, what are the foods which do not contain carbs or contain less than 5 grams of carbs per serving? So if it's, cottage cheese or paneer, cheese, curd, your vegetables, which is all your non-starchy vegetables, chicken, fish, egg, nuts, etc. Again, very important when we talk about nuts, you have to tell them that nuts and not dry fruits, because when we tell them nuts, they will go and have dates and anjeer and raisins and wonder why is their glucose level going up. Again, this has to be eaten in moderation because we have to keep a check on the saturated fat content as well as the sodium. We've had one person whose, glucose levels were really going up, and we kept asking the person, what are you eating? And they said curd. And, we're wondering with the yogurt, why is the sugars level going up? But the mother was giving 1 kilo of curd at a time. And therefore, it's very important to also mention the amount that they can eat for it to be a low carb food. Now, when we come to insulin to carb ratio, the formula is 450 for regular acting insulin or 500 for your rapid or fast acting insulin divided by the total daily dose. Again, very important is when we're doing carb counting in type 1 diabetes, it can be done for people who are on a basal bolus regimen. That means they're on a separate insulin for, a long acting insulin and a separate short acting or a rapid acting insulin. Because like Dr. Sumit said, if it's on a pre-mixed insulin, when you increase the insulin, you're not only increasing the rapid or, the short acting insulin, but you're also increasing the NPH part of the insulin or the long acting insulin. And therefore, it's very important that we do carbohydrate. Like we mentioned, again, the SPAD guidelines very clearly state that, only people with, with type 1 diabetes should be on basal bolus regimen separately and not on a pre-mixed insulin. So the formula is 450 or 500 divided by total daily dose. That will give us 1 unit of insulin will cover how many grams of carbs. Again, this is not etched on stone. We have to work very closely with the patient, look at their BG trends, look at their pre-meal readings, give them a stipulated amount of carbs, look at what is their post-meal readings, and then come to an estimate as to what is the insulin to carb ratio at breakfast, what is it at lunch, and what is it at dinner. Most often, people need more amount of insulin in the morning because of insulin resistance, and lesser amount of insulin in the night for the same amount of carbs because of physical activity and more insulin sensitivity. For very young children who need less than 10 units of insulin a day or are less than 5 years, a 300 or a 450 rule may be adaptable. So this is just the starting point, but we have to closely work with the patient. Again, CGMS, SMDG definitely help guide decision-making, and this is something which has really helped in our clinical practice to take the right decisions. So this is the example. So if the person is on, say, 25 units of total daily dose, which is your rapid as well as your long-acting insulin, so 500 divided by 25 is 20. So 1 unit of insulin covers approximately around 20 grams of carbohydrates. So if the person is eating 100 grams of carbohydrate at a meal, the person would need 5 units of insulin as per this formula. Now, there are so many different kinds of insulin. So you have the regular insulin, you have a rapid acting insulin, you have the fast acting insulin, and you have the long acting basal and the NPH insulin. So therefore, a meal prescription. It's definitely not a one size fits all. It has to be customized and tailor-made by a qualified dietitian who's trained to see children with type 1 diabetes. Now, like we mentioned, the premixed insulin, there's a lot of rigidity in terms of, the meal timings, the amount of, meals, the carbs that they're consuming, and therefore it becomes very, very difficult for our children to follow this kind of regimen. Now, when our children are on, a basal bolus regimen, so if they're on a basal analog, which is your long-acting insulin that takes care of the fasting glucose as well as the glucose levels through the day, and then you have a rapid acting or a regular acting or a fast acting before the meal, this will cover the meal blood glucose, the meal carbs. So basically, if the person is on a regular acting insulin starts working in around 30 to 45 minutes, will cover one meal and then a small mid-morning snack. Again, that is variable, because if the breakfast meal is high in fat, you may not really need to give a mid-meal snack, and therefore monitoring your SMBG readings as well as the CGMS will really help to make that decision. A person who's on a regular acting insulin before dinner would need a bedtime snack, and therefore it's important to check the glucose levels at bedtime and give a bedtime snack to avoid hypoglycemia in the middle of the night. But not every child with type 1 diabetes would need a bedtime snack. For example, if the child is on a rapid acting insulin or a fast acting insulin, then that would cover only the dinner meal, and there is no requirement of a bedtime snack if the glucose levels post 2 hours are in the normal range, and therefore it has to be customized to the insulin that is prescribed. Now we are going beyond carb counting. There are so many other factors. So many times people say that, okay, I'm taking insulin for the carbs. I've eaten 100 grams of carbs. I've taken 5 units of insulin, but still my post-meal blood glucose levels are not coming in the range. But there are so many other factors that could impact blood glucose, and they have to be also considered. One is your fasting blood glucose reading or the pre-meal blood glucose reading, for which you would need to take a correction dose. The time of the day, like we mentioned, mostly in the morning, we see more insulin resistance. Menses time, again, the glucose levels usually go up, and therefore, again, there a little bit of titration needs to be done. The timing of the bolus, in terms of when is the person taking the insulin? Is the person taking in the insulin after the meal or just before the meal? Which type of insulin? Because every insulin will call for a bolus shot. Like for regular acting insulin, you need to give the bolus at least 30 to 45 minutes before, whereas your rapid acting insulin, you can give it around 5 to 15 minutes before. Carb counting accuracy, but like we mentioned, up to 20% is fine. Glycemic index, the higher the glycemic index, you would need to take the insulin a little before time, and also maybe take more insulin. Protein content, fat content, fiber content, the physical activity, gastroparesis, stress, menses, alcohol, illness, all of this will impact the blood glucose levels. Now, when we have children eating outside, which has become a very common phenomena today, because even ordering in food has become, very easy, and a lot of children going out for birthday parties, or just dinners over the weekend. So what do we do with this? Again, if you look at the American Diabetes Association guidelines as well as the ISPAT guidelines, they suggest that dietary fat and protein should be, considered when determining the insulin bolus. And therefore, it will call for additional dosing for meals which have got more than 20 grams of fat and 30 grams of protein. And therefore, you may need to bolus, from a starting dose of, say, 20% additional bolus, and it could go up to even 60%. Again, SMBG and CGMS will help us take the right decision for a particular meal. For example, somebody's having a Burmese meal and having khao, and we know that it's got a lot of coconut in it. So again, that would increase the blood glucose levels, and it will not increase the blood glucose levels immediately, because we know that fat would increase the blood glucose levels later. So initially you will not see an increase, but you will see an increase later, and that will need an additional bolus dose maybe 2 hours after the meal. Now with the pump, it becomes very easy because pump takes into account, and today with the advanced closed loop, systems that are in place, we have the Medtronic 780G, which is the only pump which is available in India that would account for that late rise in blood glucose and would give auto correction. However, we need to put the right amount of carbs. So therefore, accurate carb counting, at least up to how much accuracy we can get, that becomes very important, because we will have to put in the right amount of carbs. And if it is a meal which has got more fat and protein, we will need to put additional carbs. Now we come to nutritional management of celiac disease. Now, gluten-free diet is usually well adapted and has not been found to be harmful to the metabolic balance of children with coexisting type 1 diabetes. And a strict GFD diet shows decrease in episodes of hypoglycemia, improvements in glycemic control and HbA1c concentrations. And like Dr. Sumit clearly mentioned, that unless the diagnosis is confirmed, we do not recommend them to go on a GFD diet. Now, management, again, when it comes to celiac disease, it's a gluten-free diet. Type 1 diabetes is carbohydrate control diet, high fiber, low to moderate GI and GL. Now, very important is to look at nutrition, nutritional deficiencies, and therefore iron, folic acid, vitamin D, vitamin B12, zinc, magnesium, calcium. So very important is to look at a balanced diet, which is again planned by qualified dietitians, ensuring that all the food groups in the right proportion are taken. Probiotics may improve gastrointestinal symptoms in patients with celiac disease. However, we need more evidence. Now, busting myths about celiac disease. I remember when I was going to a government hospital and addressing a lot of patients, meeting a lot of patients there, a lot of them told me that they ate only rice. They did not eat any other grain. So it was rice for breakfast, rice for lunch, and rice for dinner. Again, the population that I was meeting was used to eating only chapatis for, their meals. And they found it very, very difficult to eat only rice. And they were actually eating rice dosa for breakfast and rice for lunch and dinner. Therefore, it's very important to know which are the foods which contain gluten and which are the foods which do not contain gluten, because their doctors at that time, and this is many years back, they thought that only rice was gluten-free and all other grains had gluten in them. So therefore, there was not really enough variety in the diet. So barley, spelt, rye, again, rye is not the mustard, it's the other rye grain. Wheat and its products like semolina, broken wheat, bulgur wheat, refined flour and products made from it like white bread, multigrain bread, pasta, biscuits, khari, which is a very, very common thing in our children's diets. They could also be found in malt, that is malt syrup, malt extract, malted beverages, beer, barley water, brewer's yeast, food with artificially added gluten or cross-contaminated with gluten. So again, this list is very important that we share with the patients. Now, when we talk about it, I think they just wonder that, oh my God, what can I eat? And imagine type 1 diabetes and celiac. It's like a double whammy. What do I really eat? So we have to, make their life easy by telling them that, okay, there are so many options which are there. And honestly, in India, it's not very difficult to be gluten-free. You have so many gluten-free grains. And like I mentioned, we're celebrating the International Year of the Millets. And we have so many different kinds of millets, which are easily available today, even on e-commerce websites. You have amaranth, you have quinoa, you have buckwheat for those who would like to try them out. You have pulses and dals. So all your dals are gluten-free. Soya bean is gluten-free. Nuts and dry fruits, milk and milk products, all your fruits, nuts, vegetables, roots and tubers, oil, butter, ghee. Now there are so again, the guidelines in different countries would vary. For example, I was in Australia and they're very, very particular about, they do not even give oats for their patients. Whereas in our country, we would allow gluten-free oats to a certain extent. And therefore, the guidelines are very different in different countries. When we're looking at packaged foods, can you please mute yourself? Sorry. When we're looking at packaged foods, it's very important to educate our patients to check the ingredient list. Avoid buying products which mention
please mute yourself. Yeah, thank you. Sorry.
Avoid buying products which mention the following ingredients like, flour, atta, refined flour, all-purpose flour, malt, cereal additives, hydrolyzed wheat starch, wheat germ, and durum. Now, when it comes to spices, people think it's only the wheat which is actually got, or, barley and the products made from them, which will have the gluten. But hing, which is commonly used in our Indian household, may be contaminated with gluten because they usually will add wheat flour to it. So again, very important is to tell them to buy gluten-free hing. Even soya sauce or some other sauces would have wheat in it. Even when they're eating salads outside, they could, or, pasta outside, it would be made with your maida, which is your refined flour. So therefore, it is important to, we can even guide them on which are the gluten-free options available. And honestly, there's a lot available today in India. Again, gluten-free oats. Oats has got adenine, which is very similar to gluten, and some people may react to it. However, again, gluten, when we are educating them as to, buying it from a supermarket, we have to tell them to buy gluten-free oats, which means that the oats not contaminated with gluten. And there are, it's very clearly mentioned on the food packet that this is gluten-free oats, and in moderate amounts, it may be tolerated. Again, for people who have a reaction, should avoid consuming it. Now, preventive measures is avoid products with unknown methods and composition. In fact, I was talking to a restaurant owner, Udupi restaurant owner, and everybody loves idli and dosa. And he was telling me that because the cost of dal has gone up, sometimes they add maida to the batter, just to add the volume and make it a little crispy. So again, that will be a contamination. So though we tell people you can have dosa outside or idli outside, we really don't know if there is any kind of, rava or maida that has been added to the batter. Keep all cookware separately. Some people may be very, very sensitive, and we also tell them that even, when they're washing the utensils and everything, maybe, keeping the sponge and everything separate would be advisable. We have a lot of people now having their own domestic flour mills, and it's easily available. In fact, I know a doctor who's in Delhi who actually gives people a chakki, so she, she gives a lot of patients a home flour mill, and that has really become very useful for our patients. So a domestic flour mill can be used to ensure no contamination. Gluten-free restaurant options. So what can I eat in a restaurant? Ensuring that, it is gluten-free. Rice, dal, khichdi, neer dosa, idli dosa. Again, very important to speak to the chef and see, and, tell them that, you can't eat gluten. So I think this is very important for us to tell them, because they may take it very casually. Adherence to gluten-free diet, talking to the family, the siblings, and the friends, again, becomes important. Now, we have a lot of gluten-free products available. I know shops, they're on the e-commerce websites. You have so many different gluten-free options which are available, like you have the sorghum semolina, which is your jawar, you have quinoa pasta, gluten-free flour, buckwheat pasta, chickpea pasta, rice noodles, millet noodles. This is for our children who want to eat noodles or pasta. But again, as I mentioned, you have a lot of millets, you have dals, you have so many different grains, which are very local. For example, buckwheat is eaten during the Navratra fast, and a lot of people do eat, they make dosa out of it, or they make an upma out of it, or a khichdi out of it, or a dhokla out of it, and it tastes really nice. Again, the gluten-free logos. So these are some of the gluten-free logos. So to summarize, type 1 diabetes management calls for a multidisciplinary approach. Very important is to work as a team. And today we're very fortunate to have pediatric endocrinologists, who are very well trained in the management of children with type 1 diabetes. And it's wonderful working with them as a team, because we're all working towards enabling the patient get good glycemic control. Education from the time of diagnosis. Again, it's a stepped up approach. We don't start with carb counting at the beginning. Again, depends on the person's, literacy levels, the socioeconomic background. We have to keep all that in mind, and then customize the plan to the person, and then move on to the protein and fat counting. Gluten-free diet is the only treatment for patients with celiac disease, and there is no one size fits all. So thank you so much for your patient hearing. And this is my team that works with me in seeing all our children with type 1 diabetes and celiac disease.
That was a very, very wonderful and insightful lecture, and that clearly speaks volumes about the fact that I think someone has worked with these children for several years, and we get all that experience that I certainly learned a lot from that lecture. Over to you, Lekha.
Thank you so much. Sorry, to concise so much in 15 to 20 minutes is very, very difficult.
So the rest is available by buying your book from Amazon.
Yes, I have tried to share everything in my book. Thank you.
So lots of questions. Over to you, Lekha.
I know that's so
Dr.
much of
Srinivas, yeah, some questions.
You can
Yeah,
see
lots
how
in the
much
chat
it's
box.
loaded with questions, almost 15 plus. Mainly, I think it's all the diet-related questions which are there.
I think even Dr. Sumit can take a few of them.
Yeah.
Sure.
There's one question for Dr. Sumit, I think, asked by one of these people. So everybody has clearly mentioned about the latest ISPGAD guidelines, ISPAD guidelines. where they clearly say that there has to be a basal insulin and then we have to give top-ups of the shorter acting insulin. So the question is basically, if you give the basal insulin, is there a risk for hypoglycemia if somebody does not eat subsequently? I think that's one of the questions. With just the dose of the basal insulin, basal bolus, is there a risk for hypoglycemia if somebody doesn't eat well enough?
So I think the question probably means bolus insulin, because basal insulin is not really taking care of the meal insulin. So they probably meant bolus insulin. But yes, once insulin is in the system and the meal is not taken and the insulin was given for the meals, there will be a risk of hypoglycemia. That is the job of insulin, to bring down the blood sugars and control the blood sugars for the food also. So if the food is not eaten, you are not taking care of that part of food. So yes, hypoglycemia will be there. And it is best to anticipate it. So you know that the child did not eat their meal. So you can probably give something in exchange for the same, and carbohydrates could be exchanged accordingly, and whatever the child likes they can eat it, or maybe just monitoring it more frequently and giving liquids that may have a little more protein and fat, like for example milk, that has a longer duration of action also. So that could at times prevent the hypoglycemia that can come along with that.
Dr. Sumit, can I ask you one question before we go to the chat box? Do you
Yes.
find it difficult to control the sugars in a celiac versus just a diabetic? Do you find there's a difference when you're handling these two together?
So
In the sugar
initially,
control, yeah.
in their initial diagnosis, when they're actually having a lot of malabsorption, I'd also mentioned that they do at times have more frequent hypoglycemias, and then their HbA1c may actually come back as lower, or either that, or they may actually have very nice blood sugars when they're started on insulin. But once the gluten-free diet is started and the absorption of nutrients starts to happen, the blood sugar control may go haywire, and they may start to think, why am I having higher blood sugars at this point?
Okay.
So of course, for long-term complications prevention, we do want to make sure that they are on gluten-free diet, but the insulin requirement actually goes up slightly when they are started on
Nothing to
gluten-free diet.
eating. Okay, because of the better options.
Yes.
One more question that I'd like to ask before the chat box, and this is with respect to carbohydrate, protein, and fat counting. So we quite understand that if you really want to micromanage your blood glucose levels, you have to use an insulin pump and maybe continuous glucose monitoring. So in the absence of that, have you, any of you, used, let us say, calorie counting apps, like for example, Healthify Me or something, to empower the patient to do this carbohydrate or protein fat counting?
I'm actually famous for that. So, so insulin pumps, we don't need to be mandated to be on insulin pumps to have a very good blood glucose control. It could also be done on multiple daily injections. And if we are empowering our children how to count their carbohydrates and eventually use fat and protein counting even on the injections, then also we can achieve a very good glycemic control, and they can do that. So there are various apps that you could use. I think Ms. Cheryl ma'am can also tell us that, what app she is working on, because she has worked on more standardized way of measuring carbs. But yes, for now, I'm actually recommending Healthify Me to count those carbohydrates to make it a little easier for children to, get used to it. I'm actually waiting for the app that you're actually going to create. So.
That's exactly. It's going to be ready anytime soon. So we've actually we've developed our own app, and hopefully it should be uploaded this week, next week. Is still working.
Wow, that's nice.
So we have an author and an entrepreneur as well, who is making an app and making money. My God.
And really need for the art. Really need of the art.
I am not making money. It is not. We're not commercializing it. It's going to be free for our patients, and we've also done a lot of work, with the SPAD as well, and we've come out with the carb counting book for India. But again, it was a very, it doesn't include all the foods, because if you look at India, we have so many foods. Honestly, to include all is very difficult. And I think every household is so different. Even if I look at my chapati size to my neighbor's chapati, it is going to be different. The carb count will vary. And so therefore, yes, we talk about weights today. We are educating them as to, we at least ask them to buy a food weighing scale, so that they can measure the weight. And we tell them, okay, if you take so much rice, this got so much carbs. And if you have roti, we do that whole exercise with them. So therefore, it's a lot of work that goes in, with the parent. And honestly, from our team, each child has 3 people managing them. So we have 3 dietitians who are managing 1 child with type 1 diabetes. So that is the kind of effort that goes in from our team. But that's something that we do because, that's the commitment to the cause. So it's not, it's definitely not, we don't look at it as getting us any revenue. It's not commercial at all for us. It's very different.
We salute both of you for your passion. I'm going to let Lekha take over the chat box so that she can sort out the questions and ask them.
Yeah.
Thank you, Dr. Srinivas.
Thank you very much.
Dr. Cheryl, this is one of the most concerned question which most of the dietitian has. When it is just the type 1 diabetes, maybe we permit them to take chocolates. But what about when they are having celiac disease also?
Exactly. So we'll have to be careful, and we'll have to look at, nowadays you do get a lot of products. In fact, a lot of our own parents, of children with having celiac condition have come out and started making cakes, pastries, chocolates, and a lot of things, Lekha. So, they are, and we know that they're going to be genuine. So we do give them their number and references, and we know that at least they will be genuine. So a lot of them have started making it. So that is what we would. But again, it's not, as the rule goes, it's not going to be a regular feature. Even when it comes to correcting hypoglycemia, we clearly tell them that you cannot correct it with chocolates, because they look at it as treats.
Okay. And how about if you have to go for any oral nutrition supplements also, having a chocolate flavor, would you think that's okay to go for?
We'll have to see. Honestly, I haven't tried. Maybe Anuja is here. She can tell you if there is anything which is gluten-free, which is available. I haven't really had the opportunity to try.
Yeah, with flavors, I have never tried. So I was also wondering about that.
Honestly,
without flavors, we have given.
But then I do know a product, but I don't want to promote that product on this platform. But there is a product. Maybe I can tell you unofficially.
Yeah, sure.
Another, because I do not want to promote that product. But I think that is definitely one which is going to be, because that doesn't have any flavor or doesn't have any additives in it.
Okay.
There is one question. Do you trust all these brands which are there?
That's what I said. I can't
Contamination.
I was talking to somebody at a Udupi restaurant, and he was telling me that, ma'am, dal ka bhav itna badh gaya hai. What do we do? So we are adding maida, we are adding things. And I was shocked because, and I was just standing outside waiting for my order. So I got chatting with him. So what do today outside food, you can never be sure of, honestly. And that's why we do not actually encourage them. A lot of our parents carry their rotis and go and, do that. So we usually will tell them not to eat outside too much, because some of them are very, very sensitive. Again, the sensitivity varies. Some people are very sensitive. So we'll have to be careful.
Cheryl, coming to inpatients, sometimes they are given insulin and they refuse to take the food after that. So what can be done? Like the child is fussy, doesn't want to eat. So
then
how will you tackle
anything else which is corresponding to that carbs that we'll have to give them? Others will go hypo. So
yeah,
whatever
that's it.
works. But then it cannot become like, then every time the child will do that. Children are also becoming very smart today. So then they know that, okay, we'll take the insulin and we'll refuse. But then you have to give them alternate options. Or if they've eaten a roti less and you've given that much insulin, then you'll have to look at, corresponding to that, how many carbs. We'll have to try and make that up. Maybe add a fruit or something which will add up to the carbs, because otherwise hypoglycemia can become a problem.
How about tender coconut water, especially for type 2 diabetes? Do you recommend?
Again, this is something that we constantly debate about.
And especially without renal issue.
I do allow
Okay.
it. But again, looking at the glucose level, we tell them to, have it with nuts, or maybe add chia seeds to it, or even the coconut malai thoda sa usme. And then we really don't see it. And we don't give them too much again, but up to say 150 to 200 ml is fine if their sugars are in level, and pre-workout as a fruit exchange, we would give it to them.
Okay.
And honestly, we've done this, Lekha, because constantly, everybody has a different opinion, and we've tried it just with our own patients. In fact, even Kavita Gupta from Nagpur. So we both tried
Okay.
it, and we really saw that it didn't spike up the glucose levels. If it was given when the glucose levels were in range, if they did physical activity and was given in substitution for a fruit, it was fine.
Coming to, like you said, like we can go based on the RDA requirement. If the child is underweight and like after the period, their stabilized period, how do you go for the calories? Do you use the catch-up formula to increase and give the requirement?
We would give it. And again, like I said, this is again very important. And we would, even if we are moderating the carbs, maybe you can add a little bit of healthy fats in the form of nuts and seeds, and we could give that, but we would have to give them.
And how about protein? During that period?
Again, we will have to give reaching 20 to 25% of the recommendations by ISPAD is just too much. So we wouldn't go there. We will try and come somewhere in the mid where we'll try and gradually increase it. But we can't really get to 25% easily.
Okay, I'm just looking on to the questions, whether any key questions
There's
are
one,
there.
Lekha, for Dr. Sumit, malabsorptions. Do you find that a problem, Dr. Sumit?
In terms of
Malabsorption, there's a question, malabsorption of zinc, vitamin D, iron, how these can be maintained for longer time with supplements for children with both the problems.
So they're usually needed when at the initial diagnosis and maybe for some time after. Once we have started them on GFD and they're on strict gluten-free diet, then they really don't need any kind of additional supplements to say so, except for vitamin D at times, because that is something that usually tends to drop down if the sunlight exposure is not there. But other than that, like if they are taking strict gluten-free diet, the need for additional supplements on a daily basis is not there.
So you don't advise supplements on a regular basis to these patients?
I think once you
For the
put them
initial
in,
part, yes.
and if they consult a qualified dietitian who's ensuring that, and there is
That's
so
a balanced
much available
meal,
today.
yeah.
I think that is so important. And that's a message that I think we all need to give, because typically a lot of them feel that, they'll be nutritionally deficient. But if you're, you have to make sure. And you're having so many millets in the diet. You're having your rice, we don't stop rice for our type 1s, but we don't only give rice to celiacs, which honestly, it's very sad to see some of them are put only on rice morning, afternoon, night, because they don't know of the other varieties that are available.
Cheryl, coming to enteral feeds in infants. So when they're having both the like the issue of celiac also, what product would you be recommending?
Honestly, I would have no idea about this. Like, I'll be very honest. Maybe Anuja is here. She would be the right person.
In our center, what we practice is like chicken-based product. If it's fine, we go for that. And maybe the normal polymeric, which is gluten, we can dilute the dilution and go for if it's less than 1 year. That's what we generally do. Any take or any inputs from others also welcome to answer this question, because this one concern which comes off, like especially that 7, 8, 9 months, they are in the EN period. And if you don't get the product, that becomes a issue. That's another question for how to counter blood glucose spikes after exercise in type 1 diabetic teenagers. Patients goes for exercise in empty stomach. So something on add on with exercise and how their diet has to be after that.
I think that is again very important. We have to look at exercise, and again very important is what type of exercise, because every exercise will have a different impact on glucose. If they're doing an aerobic activity versus an anaerobic activity, it is going to be different. And also, never check blood glucose levels immediately post exercise, because it will usually be on the higher side. We tell them to usually, cool down and then check their glucose levels. And also very important is if they're doing any kind of activity, we'll have to give them a pre-workout snack if their glucose levels are on the lower side. So if it is below, say 120, we usually give them around 10 to 20 grams of carbs, depending again on the age, weight, etc. And then, allow them to do the exercise. Post-exercise, again, check the glucose levels, say once they've settled down, and then we would give them a snack, or if there is a meal, we would maybe sometimes have to even lower the insulin dose, or maybe give them additional carbs and take care of the late hypoglycemia that could happen, because exercise can have an impact even later in the night. So ensuring that we're taking care of that. is also very important. So, and in the pump again, I think pump takes care very beautifully of that, because it will basically lower the, the bolus that is going. So the auto correction that is going, it will reduce that, so that there is no hypoglycemia. In fact, that is the best thing that we are seeing with the advanced hybrid closed loop pumps today, that it takes very, very good care of the exercise part. Whereas the other pumps that were there, we could actually lower the basal. So that is a feature of a temporary basal. But when you're talking about additional, if the glucose levels are high, then we'll have to figure that out and then work around the insulin and the carbs accordingly.
What I've found useful is like if we use the combination of aerobic and anaerobic at the same time, then at times the blood glucose spikes tend to go down.
Yeah.
So you may not see that spike, but yeah, oftentimes it's still there.
Dr. Sumit, do you actually see a lot of patients coming with hypoglycemia? How often do you see it in your practice? Hypoglycemic attacks? Yeah.
With exercise or just?
So just generally with, type 1.
Yes, like if there is a picky eater, if they missed a snack, if they're on much more higher doses of basal, or I mean, there are multiple reasons for hypoglycemia that are there. So yes, usually what I tend to do is, so if they're coming to me for the first time, I first tell them we're going to fix the hypoglycemia first before we actually work on the hyperglycemia. You may actually see worsening of the high blood sugars because we are fixing the hypoglycemia. So
Yeah.
you have to be very patient with me, because we want to fix the more immediate threat for
Difficult,
you.
yeah.
And then after that, slowly we'll fix the high blood sugar.
The more
I agree
critical
with
attack.
that. I mean, hypo is the biggest concern. First is hypo. It's okay a little high. And like we said, we'll have to see the trends. We can't really take a decision based on one day. We look at what the trends are. If they're doing it on a regular basis, then we look at the trends and then adjust the insulin and the meals. I think for that, we definitely work together in tandem.
Thank you, Cheryl. Thank you, Sumit. I think most of the questions in the chat box are covered by even in your sections. So over to you, Dr. Srinivas.
I just have, can you repeat that question, Lekha, regarding that infants and gluten-free formula?
We have this chicken-based formula, sir, that we can go for, or like the normal polymeric formulas,
No.
which we.
I want you to repeat the question.
The question was for the infants, what type of formulae can be used when they are on EN, for the EN formula. For less than 1 year, there is a concern like, what formula can be given when they're having both celiac as well as diabetes.
What is the problem with the standard infant formulas?
They might have gluten in that.
But why? I mean, they don't say they have gluten in that.
So that's what is the question, whether it's there. We need to recheck on that, sir.
I think very important is to check the food label, speak
food
to
label.
the company person. I think very important to speak to the medical advisor from any of these companies and check.
No, none of the infant formula ever have gluten. See, the very fact that celiac disease is suspected in children only after weaning. Infant formulas are substitutes for breast milk, so they essentially contain only lactose as the carbohydrate, and they don't contain any wheat or any form of protein. So none of the infant formula ever contain gluten. So that is something that can be clearly told. So we start suspecting celiac disease because children who are introduced wheat as part of their weaning diet develop symptoms after 6 months of age.
I agree.
So a standard infant formula are not a problem. So we usually diagnose celiac only after infancy, because it takes some time for them to start developing diarrhea and malabsorption and everything, etc. So very rare to diagnose celiac before 6 months.
I agree.
That's all. Okay.
Thank
So
you,
we
I
sir.
thought it was not up to 6 months, right? You said later. What was it?
Infant. It was just to mention infant. The
No,
question was for infants. So probably even for a 1-year-old, they are telling we are not sure about the question.
Yeah.
So
No,
maybe
the
it's like
the
one
question
not
was-
Stage 2 infant formulas too.
infant.
Yeah, the question was, is there any concern of using infant formula in children who have celiac and
No.
diabetes? I think the answer should be
No.
no. Standard infant formula are safe. That's the answer.
Agree.
Okay, sir.
It was a really very engrossing and really wonderful session. I think you've beaten out most of the doubts. There's been a wealth of information. I do agree that 1 hour sometimes is not sufficient to clear all these doubts. But certainly you have given us a lot of knowledge, and this will help us to actually go delve deeper into this subject. And we will go through the book that Cheryl has published as well. And thank you so much. It was a really, really wonderful session, very enlightening session for everybody who, that's why there have been so many questions from people who are asking, when will the live recording session be there? So I am wondering that they are not listening to this live session and they are asking already.
Asking for the recorded one.
Correct.
No, they want a revision, so they want to
Revision.
re-listen to the whole thing.
जब काम पे आता है रेफर करने के लिए हेल्प होता है ना. हमेशा when you have the patient in front, you want to go behind and see whether what you're doing is correct.
Correct.
So that's why it's like a reference speak now.
Thank you so much. Yeah.
Thank you so much.
Thank you.
Yeah. It's been a pleasure to be here.
Dr. Cheryl.
Thank you.
Thank
So
you.
we come to an end of an amazing session. We'd really like to thank and take this opportunity to thank Dr. Nanda Kumar Jairam, who's the president DAPIO, and Dr. Sushil Jain, who's the honorary advisor, for this great opportunity to collaborate with DAPIO, an excellent platform. I would like to really thank our chairperson, Dr. Srinivas. It was really great to have you there with your insights. And our excellent speakers, Dr. Sumit Arora and Dr. Cheryl, who shared their insights and expertise with us. Very, very interactive session. You've inspired us with your vision and wisdom, and thank you again. I'd like to thank our moderator, Lekha, and all the participants who engaged in this lively and stimulating discussions and the question answers, which made it so lively and interactive. Would again like to thank the entire DAPIO team and the IT staff who worked behind the scenes to make this a big success. Thank you once again for being part of this DAPIO dietetic session, and look forward to the next. Thank you so much, everybody.
Thank you.
you.
Thank you for
I'd like
having
to
us.
thank Dr. Anita also for organizing the whole event. Thank you, Dr. Anita.
Thank you so much, sir. Thank you.
Thank you.
Thank you. Thank you so much, everybody.
Bye, everyone.
Bye-bye.
Thank you, everyone. Thank you.
Bye-bye.
Thank you, Anita ji.
Bye.